There's little doubt that COVID-19 is associated with increased incidence of thromboembolic events. Another biomarker around the corner being extensively used is DDimer. Are we correct in our approach? To discuss this, I have Professor Roopen Arya with me. Professor Roopen Arya is Professor of Thrombosis and Hemostasis at King's College Hospital in London. He has been National Lead for VTE and is Director of the National VTE Exemplar Centres Network in England. He has extensive clinical and research experience of thrombosis in COVID-19. Professor Arya, welcome to podcast ISCCM.
Thank you for the kind invitation to join with you today, and I welcome the opportunity to share my experience.
So DDimer it could be an inflammatory marker as well. It's not always a thrombotic marker. So if I have to use a DDimer as a trigger, so what should be the trigger point? It should be just more than a normal or double the normal, triple the normal, 5 times the normal. What is the trigger point if I have to trace a DDimer for starting the therapeutic dose?
Thank you for that, I think, very important question. We know that the DDimer would be elevated in virtually all the hospitalized patients. And in my opinion, the DDimer testing was certainly overused, particularly early on in our experience of COVID-19 disease. I would certainly recommend that it's useful to measure in patients on admission to hospital just as a marker of the coagulopathy that is common in the disease, and perhaps there's a utility in critical care patients to measure it on a daily basis or an alternate daily basis, where it provides just one marker among many, and including the clinical indicators, of the patient's journey and the patient's progress. But in my opinion, there's no strong evidence to support DDimer triggers to guide treatment, nor for the dose adjustment for anticoagulation, nor in helping make the decision about post-discharge thromboprophylaxis, because really there are no studies that would firmly support that practice. So I would recommend that we check DDimers less, but certainly I think there is a utility in critical care patients to measure it maybe every other day amongst the markers.
So you touched my last question as well. I was going to ask you, how long do we have to continue these in post-discharge patients as well? I mean, is there any role of continuing with the anticoagulants or oral DOACs maybe in the post-discharge patients?
In my opinion, we should not be routinely using post-discharge thromboprophylaxis because our own group, in fact, published quite early on in this our experience in nearly 2,000 patients, where we showed that post-discharge venous thromboembolism was not a significant problem in patients hospitalized with COVID-19 disease. And subsequently, there have been another 2 studies which also confirm our conclusions. And even before COVID-19 disease, the evidence for the routine use of post-discharge thromboprophylaxis in medical patients was very weak, and it is not something that we were routinely doing. So to summarize, I would not routinely recommend the use of post-discharge thromboprophylaxis in patients hospitalized with COVID-19 disease. But I certainly think there is room for an individual case-by-case assessment, when there are cases who, upon discharge, do have maybe a poor performance status or other risk factors, for example, like cancer, in which we might decide that there's a sufficiently high risk to give post-discharge thromboprophylaxis for a few weeks, either with low liquid heparin or with a direct total anticoagulant. But I would not do it routinely.
Yeah, so agreed. So we'll not do it routinely, but might consider in the high-risk cases, as we always do. You can have the concluding remarks.
Thank you for giving me the opportunity to share our experience in what has been a very, very dynamic field. I think, without doubt, the burden of thrombosis in patients hospitalized with COVID-19 disease is extraordinary. So we should be aware of this risk and use thromboprophylaxis as appropriate. It is important also that we stick to the evidence base, because sometimes there's an expectation to respond even before the paper is published. But there's no doubt been a huge acceleration of research around thrombosis in COVID-19. But we must also understand that the use of anticoagulation and the emphasis on VT prevention is only one aspect of the overall care of the patient. The improved outcomes we have been seeing have been due to an incremental effect, with the better use of proning, hydration of the patients, the use of steroids in hospitalized patients, particularly on supplemental oxygen or in critical care, the use of antivirals and immunomodulators. So it is overall care of the patient that is important. And I think the ideal approach to VT prevention is to prevent COVID-19 through the social distancing and taking the appropriate precautions, wearing PPE, and ultimately through sufficient rollout of a vaccination program. Thank you.
Thank you, Professor. Thanks a lot. That's all for today. Thanks for listening. See you again.